and potential spaces. When I went through sexual anatomy, which was back in the 80s, we used to have a course that was taught by residents, and they basically would teach aspects of sexual anatomy. Of course, there's a lot of different modalities then. We certainly didn't have the sophistication we have now. But one topic, in fact, I remember the radiologist's name was Dr. Saunders, said that when you look at advanced imaging, it's just not enough to look at organs, organ systems, how they appear and how they change with pathology. But you have to look at where fluids collect, whether it's blood, whether it's an abscess, whether it's things like ascites, because during your scan, you oftentimes get an indirect feel for where the pathology is. And what this involves is being aware and looking for things that build up in what we call gutters or peritoneal reflections or folds. So we're going to talk about that as the first stop along the way of the abdomen and give you a basic understanding of what we're dealing with here. I think probably everyone has already covered the peritoneum to a large degree, but just from a basic definition perspective, it's a serous membrane that surrounds specific tissues and cavities within the abdomen. Some of us, as we go through our basic A&P class, will view the peritoneum as somewhat of an envelope, might be the best way to explain it, and that it basically will surround the abdomen, and certain organs and things within it would be defined as being intraperitoneal, and things that are behind it would then be referred to as retroperitoneal. But for the most part, we'll find that the serous membrane goes in and around specific organs, organ systems, and different regions of the abdomen. So therefore, what structures we define as being intraperitoneal will be different than what we expect them to be. And when we look at the retroperitoneum, you're going to find this is a complex region. So complex that we further divide it into three compartments referred to as the anterior perirenal space, the perirenal space, and then finally one called the posterior perirenal space. And there's certain organs located within each of those. And then those organs that are found within that region, within that double membrane serous layer of tissue, would be defined as being intraperitoneal. There's one area that we didn't get into, which is infraperitoneal, which we'll cover when we get into pelvis. This is kind of a vague diagram, but what you have is some drawings that kind of illustrate what we're dealing with. When we look at structures such as the liver, we look at a portion of the stomach, and we look at the spleen. These structures are defined as being intraperitoneal. And the reason for it is the peritoneum basically will come in and around these different structures. In doing so, they'll form certain pockets or pouches, and all of the organs in this one area would be defined as being intraperitoneal. I'll give you a list of which organs those are. And then certain organs are found behind it in organ systems, such as the kidneys, the adrenal glands. One that's really not well defined over here is the pancreas, which is a retroperitoneal structure, and others as well. So you have this large area back over here that's retroperitoneal, and to a smaller degree, you have the intraperitoneal structures. Over here kind of gives you a little bit more of a diagram. This is kind of loosely defined in terms of what the peritoneum really involves with. It goes in and around tissues rather than produce that envelope effect. So it's really complex, and because of it, it forms those different pockets or pouches. For the most part, when you're looking at intraperitoneal structures, they would include things as the stomach, the liver, the small intestine, a portion of it in terms of the jejunum and ileum, but the C-loop of the duodenum is considered to be retroperitoneal. And the reason for that is that it will be associated with the head of the pancreas, which is retroperitoneal. Along with the liver would be the gallbladder, spleen, as we mentioned before, and then the large intestine basically is going to dip in and out of the peritoneum. So as we break it down into specific portions, for example, the cecum would be intraperitoneal, the ascending colon would be retroperitoneal, the transverse is intra, and goes in and out from that perspective. So this is basically the structures that would be considered, or at least components, of the large intestine that would be considered to be intraperitoneal. Okay. Infraperitoneal, I'm not going to worry about these yet. We'll get into this in the pelvis, but certainly urinary bladder, the uterus, ovaries, rectum, distal ureters, prostate, and testes, all of which are found beneath or below the peritoneum. Therefore, they're classified as being infraperitoneal. Retroperitoneal structures, basically, they're rather complex. So in medical imaging perspectives, what we do is we subdivide it into 3 compartments. Those 3 compartments would be anterior pararenal, perirenal, which means in and around the kidneys, and then finally the posterior pararenal compartment, which mostly will contain muscles and certain connective soft tissues. The one that's the busiest, for the lack of a better term for it, would be the anterior pararenal compartment. Within it, you're going to have the pancreas, ascending, descending colon, the C-loop, as we mentioned before, of the duodenum, and then the upper rectum. The rectum itself is complex. A portion of it would be considered to be retroperitoneal, and then the lower portion would be infraperitoneal. Those structures that are within that compartment of the perirenal space would be the IVC, kidneys, adrenals. There is a protective fascia that is surrounding the upper pole of the kidneys that hopefully is going to be a barrier that prevents any infection from the kidneys entering and involving other organs within the abdomen. It used to be referred to as Gerota's fascia. Some textbooks still call it that. Others refer to it as the renal fascia, and then the proximal ureters. And as I mentioned before, the posterior pararenal compartment would be the psoas muscles, quadriceps lumborum, and a couple other muscles we'll talk about as we work our way into abdomen. So when you look at retroperitoneum, you have to realize which compartment you're talking about, whether it's the anterior pararenal or perirenal or the posterior pararenal compartment. Questions on that? Gutters, cul-de-sacs, recesses, and spaces. It seems that whether it's a certain discipline within our profession or if it's different textbooks, they'll use different terms for these basically regions or pouches or spaces that are created by the interlacing of the peritoneum in and around certain organ systems. So what you have basically is as the peritoneum comes in and out, it's going to form some larger recesses or pouches that would be an opportunity for fluid to be building up in that area in the cases of ascites or trauma. In other cases, what you have is what's referred to as a reflection. A prime example of it is that in the female, where the uterus is anti-flexed over the bladder, there's a tiny portion of the peritoneum that comes in between those 2 structures and comes back out. Very small, and that's simply a fold or what's referred to as a reflection. Normally, these spaces, cul-de-sacs, pouches, whatever term you want to refer to them as, are typically empty in terms of just being a potential space. Nothing is within them. Again, when you have pathology, you have trauma, fluids can build up because oftentimes these fluids will seek an area that's open and an opportunity for it to build from that perspective. So it's important for us to be aware of it from that end. When you look at major recesses that you need to be aware of, there are 2 that are adjacent to the ascending and descending colon. That's referred to as the right and left paracolic gutters. You're going to find them lateral again to the ascending and descending colon. The right one is deeper and wider, so therefore oftentimes it'll pick up fluid, for example in the case of ascites, or maybe a hemorrhage within the liver itself. The left is a little bit lower, but it does communicate with the pelvic region as well. One of the ones that we'll sometimes see in terms of issues with renal and liver failure is referred to as the posterior and anterior subhepatic space. Old terminology referred to it as Morrison's pouch, but there's other terms for it, such as hepatorenal and infrahepatic pouch or spaces. So this one oftentimes will show up with imaging when patients have pathology present. And then finally, there's one right below the diaphragm referred to as the suprahepatic or subdiaphragmatic space. And that oftentimes will show any kind of buildup of fluid on the upper portion, the ventral surface of the liver. When you look at them, and we don't really need to, these are so vague, but basically you're going to find that these opportunities where these folds occur, there's going to be a large one above the liver. That's referred to as the subdiaphragmatic pouch right over here, also referred to as the suprahepatic. You have another one that's going to be seen below the liver, between the liver and the kidney, called the subhepatic pouch or recess. You have two large gutters over here, the right one being larger and wider, referred to as the right pericolic gutter, and then the one on the left, a little bit smaller, but a little bit longer, goes into the pelvis, referred to as the left pericolic gutters. All these spaces here, keep in mind, is formed by the peritoneum, and they produce these potential spaces. They're not significant unless there's a bleed, unless there's trauma, unless there's signs of ascites or other infectious processes present. So you need to be aware of them, at least in terms of their location, as you move into your modalities in regard to looking at different forms of pathology. This is kind of a vague image right over here, but basically what it tries to illustrate is that these pouches and spaces within the peritoneum somewhat communicate together because the spaces are somewhat open, and fluid oftentimes may come or originate along the stomach region and may end up in the right colic gutter from that standpoint. So it just depends in terms of how much fluid there is and how it migrates to different portions of the abdomen. Here's a liver scan. We have the spleen over here. We have, of course, the spine. You can see we're in the upper portion of the abdomen. And what you have is the liver over here, and there's a large fluid collection right below the diaphragm. So again, you have to be aware of these areas so that you can pretty much know what you're dealing with when you're scanning your patient. Here's one on ultrasound. Here's our spleen. Here's our left kidney right over here. And you can see that there is a little fluid in this region over here called the splenorenal compartment right over here. So once again, to be aware of those pouches is important as you scan your patient, regardless of the modality, to see if there's any abnormal fluid in these areas, in and around, in this case, spleen. With spleen, we're always concerned about hemorrhage. So oftentimes that turns out to be a blood medium. Here's a CT scan with contrast media. Kind of hard to pick up right over here, but in the right colic gutter, you're having a buildup of fluid. Reason for it, we're not sure. It could be ascites from that perspective. It could be a small amount. It could be a tremendous amount of fluid. Another ultrasound in terms of the subhepatic space right over here. Here's liver, here's kidney down here, and you see a little fluid building up in both cases right through here. So again, for the novice who's not aware of these pouches, you're not sure what you're seeing. In reality, they're significant from the standpoint of pathology. Morrison's pouch, again, oftentimes between the kidney and the liver, you'll get a medium of fluid right through here, and that could be related to liver failure, other pathological conditions, cancers, things like that. So once again, these pouches become significant from the standpoint of being aware of them. So what I'm going to ask you to do is to make sure as you go through your abdomen landmarks, be aware as I cut through these once again of what is considered to be intraperitoneal, what is considered to be, let's go back one, retroperitoneal, and which of these organs fall within a certain organ, their organ's region. There's a quiz available for you that you can go through and hopefully reinforce that. Questions on that? All right. Another area I think is really quite important is going to be in the area of the portal system. Again, you may have some exposure to this already, but the portal system is unique from the standpoint that everything we've talked about so far, you have arterial flow through different organs, organ systems, and then of course blood, deoxygenated blood will then be returned to the right side of the heart. It's reoxygenated through the lungs, returned through the arterial circulation. In the case of the liver, what happens is that you have certain veins in the form of the splenic vein the inferior mesenteric vein and the superior mesenteric vein that will have certain compounds within it, which could be fatty in composition. There can be certain heavy molecules that are contained within that venous blood from the GI tract that would probably produce problems for the patient, infections, things like that. So the liver has to become involved with that blood before it's returned to the general circulation. That's the role of the hepatic portal system. What it's going to do is take that blood from the spleen, from the GI tract, it's going to take it through the liver, it's going to go through a process of filtration, for lack of a better term, and then it's going to finally be returned back into the IVC and eventually returned to the right side of the heart. So the portal system becomes really important in terms of maintaining the proper sense of composition to the blood itself and removing certain elements from the GI tract that are introduced into the blood that could be a problem. We talked about before, what you're going to have is that you're going to have a superior mesenteric vein that's going to be drawing blood from different portions of the small intestine, and the majority of the large intestine that again contains different elements, different minerals, proteins, amino acids, and it's going to be skirted back not into the IVC but through the SMV. The IMV, smaller in size, not as dominant of a landmark, is going to take the blood and elements of the GI tract that's being not used or returned back in general circulation, and it's going to be drawn up into the inferior mesenteric vein. The spleen basically is going to be responsible for the recycling, for lack of a better term, of red blood cells, which when they're broken down produces certain compounds that once again you need to filter out before they're returned back to general circulation. So what you have is three tributaries coming together that are going to form one portal vein. And they're going to be formed by the splenic vein, the inferior mesenteric vein, and the SMV. Then that blood is going to be skirted into the liver, go through a process of filtration, and then we'll find there are three major hepatic veins that will then return it back into the IVC. Kind of a more simplistic view of what we're just showing you. Basically, you have the IMV over here, SMV drawing off different elements from the GI tract on the right side and certain portions of the small intestine. They're going to all converge, and we'll use the word a confluence will be formed, and then from that standpoint up toward the liver, it forms the hepatoportal vein. What you see over here with this IV contrast study on the CT is that you have your spleen here, you have your pancreas right through here, and this little contrast enhanced area would be the splenic vein. This head-like structure is the terminal end of the SMV. In imaging, when these two come together, we'll use the term portal confluence, the portal confluence. Regardless of the imaging modality, this becomes an important structure to be able to identify. And oftentimes, based on the shape and dimensions, you may have early signs of liver failure. So oftentimes when patients are going through a certain stage of liver failure, the portal confluence will change in terms of its dimensions and its appearance. But collectively, this is called the portal confluence, which is a term we use in imaging, not so much in A&P. From this point up superior, then we have different elements of the portal vein created. So here's what we have. We have IMV oftentimes will show up as a landmark. The SMV will terminate, join up with the splenic vein. It produces that area called the portal confluence, and then as it moves toward the liver, then we're going to refer to it as the portal vein. Questions on that? Again, a little bit more of a simplistic view of how it all works, really complex. And the thing you have to keep in mind is that when you look at the SMV, it is the major conduit that carries blood from the GI tract back into the liver. So when you have disease, tumor, whatever that involves this vein, oftentimes the patients will really suffer from the standpoint of liver failure because the ability to take all that blood that now needs to be filtered by the liver is being impeded by the thrombus, by the tumor, whatever it may be, and it will impede the amount of blood coming back through the portal vein.
Where would the IVC be located?
The
If
IVC
where it wasn't.
up here, so we're going to show you that here in a moment. So it's going to come in once we have those hepatic veins, once the blood's ready to return back to the central circulation. So again, here's what we have before. These are labeled for you. Splenic vein, we can't quite see the IMV. It might be right about here. SMV is going to terminate right here at this point, basically behind the head or neck of the pancreas. Collectively, we'll refer to it as portal confluence. As we go up, what happens is that you have a small fissure right over here, referred to as the porta hepatis. We'll give you a better feel for that later on. But what you have going superior is the actual main portal vein. It will once again leave the area of the pancreas. It's already been formed by that confluence, and then it begins its journey in toward the liver. This space is significant. We'll get into something referred to as the hepatic triad. Two of the structures within it is going to be portal vein, and the smaller of the two, right over here, is going to be hepatic artery. So those two structures will be within that portal confluence.
John, can you go back a slide?
Yes, ma'am.
It's labeled right there.
Which one?
The IVC.
Oh, over here? Yeah, SMA over here. Which one are you referring to?
The one that's kind of where I think the I is where the rib is on the left side, right? No, the lowest one on the left side.
Right here?
No.
Coming up this way?
On the right side.
Oh, the right side of the patient, but the left side of the screen.
It's that big circle.
Oh, what? Oh, IVC. Oh, you're right. That is IVC. Thank you, Mackenzie. Yeah. This would be the IVC. But when you get into the portal system, it's going to be seen more significant up here. You're right. That's IVC. This is abdominal aorta right over here, and SMA. So I didn't. Sorry about that.
He was just asking, and I saw it.
What is that structure in terms of?
He asked where it was in relationship, and I saw it labeled. So.
Good work. Good work. All right. Again, portal vein, and then what happens then, as it goes through into that porta hepatis, which again is that space along the medial aspect of the liver, it will subdivide into two major branches. One is going to be the right portal vein, and then as it goes further up toward the left quadrant, it will be then left portal vein. So up here would be the left coming away from the trunk. Below, if I can go back, would be right portal vein, right through here. Again, this little line through here would be hepatic artery. Here basically shows you that when the blood being carried by the portal vein has gone through the liver tissue, the different beta cells has gone through a process of filtration. Now that blood is then going to be skirted back through different tributaries within the liver tissue itself, and then channeled back into three major branches. These major branches are referred to as the hepatic veins. So they basically going to take that blood that now has been filtered and return it back to the IVC. Again, it gives you a different example of it. The three major tributaries that we see with those hepatic veins would be the left, middle, and right, all of which are going to lead back into IVC. When you look at it through an imaging perspective, this is an ultrasound, what you see in part is the left, middle, and the right. Here's your IVC over here. So the rule we follow is that vessels that are tracked or traced back to the IVC have to be hepatic veins. Whereas if I go back up here, any structures that's within that space over here has to be one of the three members of different structures, one of which is portal vein. So portal vein is going to be coming through that space called the porta hepatis. As we work our way through the liver, it forms hepatic veins that lead directly to IVC. From a CT perspective, once again with IV contrast, The left doesn't show up very well, it's right over here. The middle and the right, all of which that are leading back into IVC right over here. So the way to distinguish between portal veins and hepatic veins is what do you see within the porta hepatis and what do you see in terms of what leads directly back to the IVC. In this case, it would be hepatic veins. Questions on that? So what you've seen basically is the hepatic portal system where you simply take that blood from the GI tract through the portal vein, goes through a process of filtration, and eventually is carried back to central circulation through the hepatic veins, through the IVC, and eventually into the right side of the heart. All right, a couple other structures I want to talk about in imaging. Here we have the superior portion of the liver. Here's the inferior margin over here. And there's a double layer of peritoneum that basically is going to go along this portion of the liver, which we refer to as the falciform ligament. The falciform ligament essentially is a triangle-shaped type of connective tissue, somewhat fatty in composition, that will be connected between the diaphragm, between the anterior abdominal wall, and run right through this portion of the liver. Within it, we'll talk here in a moment, it's going to, on the lower margin of it, it contains a structure referred to as, old terminology, ligamentum teres. The new term for it now is round ligament, the round ligament. We'll talk about its significance here in a moment. But from the standpoint of imaging, whereas the liver has 8 different segments to it, we look at it from 2 major portions in imaging. We have the right lobe and the left lobe over here. In imaging, the falciform ligament becomes a dividing point. So you have the larger right lobe and the smaller left lobe, all of which are being defined where you find the falciform ligament. The falciform ligament basically is fatty, as I mentioned before. This is a dissected segment of it. So it has somewhat of a triangular shape to it that allows it to connect to the diaphragm as well as the anterior abdominal wall. And it's going to run basically right through the mid portion of the liver. Within it, you're going to have a small fibrous tissue referred to as the round ligament or ligamentum teres. Once again, we use this as a dividing point between the right and left lobe. The round ligament basically is the obliterated umbilical vein. So with the fetus, whereas in the heart we had blood that rather than go into the lungs was being skirted by 2 structures, one of which was the foraminal valley and the other one was the ductus arteriosus. It basically prevented blood from going, venous blood from going back into the lungs and the aorta and then being returned back to the veins itself. In the case of the liver, that's when the last organs become active in terms of the fetus. So what happens is the blood that comes through the umbilical vein, rather than enter any aspect of the liver because it's still developing, is going to be skirted through the umbilical vein, and then eventually it's going to reach a structure called the ductus venosum that then will return the blood back into the IVC, which we'll show you here in a moment. So the liver itself in the fetus never gets involved. When the child is born, of course, we cut the placenta, the cord itself. Over a short period of time, the umbilical vein will become obliterated or become fibrous, and it will become solid. It will reside below on the lower margin of the falciform ligament. From our standpoint, it will serve as a landmark. So when you look at the liver itself, it happens to be on a CT scan, what you have is what appears to be a fissure, and then in this one example, a small dot. In reality, there's a small cleft, small recess along this ventral portion of the liver, but what appears to be a space or large opening, in reality is the vast difference in terms of attenuation between the liver parenchyma or tissue and the fatty composition of the falciform ligament. So you look at this and think it's a fissure. In reality, it's the vast difference in attenuation between the falciform ligament and the surrounding liver tissue. Within it, based on the individual, based on its appearance and size, you may get an inkling of the round ligament. So this is basically what remains with the obliterated umbilical vein. So when you look at this, keep in mind, this is the falciform ligament. Within it's going to be the round ligament, falciform ligament, and then the round ligament's right within it. Again, it looks very unequal, but the falciform ligament will be the dividing point between the right and left portions or lobes of the liver. Questions on that? Once again, you're going to have that umbilical vein in the fetus come through. It's kind of an inverted view of the liver. Come through. It's not going to interact with the liver. Then it's going to reach that structure called the ductus venosum, and then it's going to quickly take that blood and return it back to IVC. So it's going to bypass the entire liver. Once again, when the child's born, we'll cut off the placenta, the umbilical vein will be nipped. It will quickly obliterate, and now this becomes ligamentum teres, which now we refer to as round ligament. And this now, rather than ductus venosus, becomes the ligamentum venosum. This structure doesn't stand out as much, at least on CT and MR, it does with ultrasound, than what you see here on the diagram. But basically it just shows you how that blood now is going to skirt the liver itself and go right into IVC. Of the two structures, the one that's most significant will be the round ligament. Hepatic triad, let's talk about that now. When you look at the space within the medial portion of the liver, we define that as, once again, as the porta hepatis. It's nothing more than an opening within the liver itself, and three things typically are found within it. In imaging, we refer to it as the hepatic triad. The three structures that you find within it would include portal vein, hepatic artery, and the common bile duct. Of the three, these two pretty much become evident, whether it's going to be through MRI flow void artifact or if it's going to be contrast induced CT scans. Of the two, the one that provides the greatest amount of oxygen to the liver tissue will be portal vein. The reason for it, it's a large pipe that goes, or pipe or vessel, that goes into the liver, and venous blood always has a percentage of oxygen still within it. It's relatively low for most structures and most tissues. But in this case, it's such a large volume of blood coming through the liver that 75% of the oxygen needed by the liver is provided through the portal vein. When you look at the comparisons in terms of diameter, the hepatic artery, a lot smaller in diameter, therefore it only provides basically 1/5 or 25%, give or take, of the oxygen needed by the liver. It also tells you that when you have a thrombus, you have some kind of tumor involving portal vein, oftentimes the patient will begin to go through different levels or different stages of liver failure from that end. The CBD would be the other structure that we find within that space. You don't normally see it unless there's some kind of obstruction or tumor involving even perhaps the distal end of the common bile duct. When you look at the porta hepatis, again, this is space right through here. The larger, given the fact that you have IV contrast for the CT or flow void artifact with MR, the larger of the two will be portal vein, and the smaller, which is coming away from the celiac artery, would be the common hepatic artery. So the two, you can pretty much tell the difference based on their size or diameter. Once again, remember, if it's within the porta hepatis, it has to be portal vein. If it's going back or traced back to IVC, it would have to be hepatic veins. Finally, as we begin our journey down the abdomen, it's important that once we leave the diaphragm region, that you know the major branches of the abdominal aorta. So as we work our way from top to bottom, you'll find that the celiac artery will be the first major branch of the abdominal aorta. Relatively short, probably no more than 1 centimeter in length, coming directly anterior from the abdominal aorta. And then it's gonna quickly trifurcate into 3 structures. 2 we'll pretty much be able to tell. That would be the common hepatic artery and the splenic artery. The left gastric, not so much. It kind of convolutes, it's hard to see, but it does go through a process of trifurcation. That will be our first branch as we work our way from top to bottom. The second one basically is going to be the SMA, which kind of shows up above the renal arteries. Diagram doesn't do justice for it. Oftentimes it'll show up near the area or level of L2. It's once again going to come out directly anterior, and then it's going to begin to move more inferior as it reaches into different portions of the mesentery. The right and left artery would be the third major branch of the abdominal aorta. They'll run lateral, and the left one's going to be a little bit longer because of its location within the left kidney. The right one would be, of course, pretty easy to pick up from that standpoint. Keep in mind about this, the renal arteries are going to be found posterior to the renal veins, first of all. Secondly, the renal veins will be larger in diameter. Then finally, as you get down toward the lower portion of the abdomen, you'll find your L4, L5, the inferior mesenteric artery. Kind of hard structure to pick up. Once again, it's going to be directly anterior to the abdominal aorta. It kind of lays on it, so it doesn't really stand out as a major landmark. And then as we get down into the pelvic region, we'll then bifurcate the abdominal aorta into the common iliac artery. So we'll see that transition, just the start of it anyway. So from our standpoint, the way we're going to perceive or define abdomen is going to be from the diaphragm down to basically the iliac crest. That's going to be our definition of abdomen. During that region or during that level of anatomy, we're going to find pretty much all these major branches. We'll see celiac artery, we'll see SMA, we'll pick up renals, and maybe if we're lucky, we'll get a little bit of the inferior mesenteric artery. Questions on that? All right, guys, that's it for today. On Monday,